Okay, so this is hypertension 202. I guess it's organic chemistry and not inorganic. But we'll incorporate some of the principles of basic hypertension. But I do want to talk to you about resistant hypertension because it's what I do now. For years, I've been, like yourselves, a primary care specialist, I think which most of you are, and seeing patients with new onset hypertension or early hypertension, and always, wondered how to approach the patient that was on multiple medicines not being controlled, and what can we do to further improve their control. So I wanted to take the opportunity to talk to you about resistant hypertension. I think it's very important, and that's what I do now at the medical school. I have a referral practice. I only take patients from clinicians who are wrestling with patients that they can't control, and we'll talk a little bit about this. Now, I don't know if we need any update on these audience response questions that I have in here. Do they know how to do this?
There's a slide there.
There's a slide, okay. Texting instructions. So I'm going to ask you some audience response questions, and I'd like you to take out your phone or your device, whatever you're using, and I'd like you to text SMA. Hopefully, how many of you have a device you can use? Raise your hand. So some of you, yeah, come on. I need everybody to do it. I'm not going to track this.
I have a flip phone.
I have a flip phone, too. Do you have a flip phone?
Yes, I do have a flip phone. But I can't
You see, and you said earlier you never agree with anything I say, but Ronnie, we both have flip phones. This is a club.
Shows you how old we are.
But it would work in here. So please, take out your device, because we need some interaction. It helps me to know which way to go with this talk. So, can all of you...
Shout it out, Jan.
What's that?
We'll shout it
Shout it out, all right. Text SMA. So you're going to text 22333 one time only, and then you're going to respond A, B, C, D, or E to the question, okay?
You should get a response back from it that says that you're connected.
And I really appreciate y'all doing this. It really helps at the beginning and at the end to see how much we've learned. Okay, we're ready?
Once you connect, then you'll just respond to the answers.
Okay. Are we ready? Here we go. So here are your pre-test questions. According to the NHANES data set, the estimated prevalence of resistant hypertension in the United States is A, 1% of all adults, B, 5% of all adults, C, about 13% of adults with hypertension treated with antihypertensive agents, D, about 50% of patients with renal kidney disease, or E, about 20% of hypertensive drug-treated adults with hypertension. Please answer now. So text A, B, C, D, or E. Yeah, unfortunately, you do see the answers as they come in, so I'd like you all to kind of do this together, you know. This is Stanley Kaplan, no looking over the shoulder. Paula, this influences people, Well, it's a good tool for education, and I like it, so I appreciate y'all taking part with me. But we only have 7, 10 answers. I'm going to walk around and see who's not doing it. Okay, do we have to? Okay, so we're done? Here we go. Okay, well, okay. Approximately what proportion of patients with resistant hypertension by clinic measurement are shown to actually have white coat hypertension when using 24-hour ABPM? Nearly 0, less than 10, about 1/3, more than half, none of the above. Please answer now. You've got your patient, you're in your clinic, patient looks elevated. What percent actually have white coat on 3 or more medications, high clinic pressure? I can't tell what that first answer is. Interesting. Yeah. Yeah. How many of you are not taking part? Please raise your hand. 1, 2, 3, 4, 5. Boy. In the future, we reduce tuition fees for participation. Okay, we're going to move on. Now, how confident are you in treating a patient with resistant hypertension? From not at all to very. Please answer now. This tells me if I can stop. Wow. Okay. We'll keep going. Okay. So here's what I'd like you to understand. Understand the definition of resistant hypertension, discuss the clinical workup of resistant hypertension, including the importance of 24-hour ABPM, and to recognize the importance of lifestyle modification and the evidence for the use of chlorthalidone versus hydrochlorothiazide and mineralocorticoid receptor antagonism, spironolactone or eplerenone, to improve blood pressure control in those with resistant hypertension. So here's a patient, Sam. He's 58. He's got a 20-year history of hypertension. He's new to your practice. He's got a BMI of 32.2. He has no history of ASCVD, no history of diabetes or other vascular disease. He's been treated, he tells you, with antihypertensive drugs for the past 10-plus years, including a combination of diuretic ACE inhibitor, but it had to be stopped due to a cough. He states his blood pressure has never been well controlled, and his physicians have always been concerned over this issue, because that's an important question you ask the patient, because this is the first time you're seeing the patient. You want to get a handle on how well they've been controlled over their lifetime. When seen by you, he's on losartan HCTZ 125 and amlodipine 10. His blood pressure today in your office is 144/94, and that's the average of 3 pressures, and he's not orthostatic. His physical exam is unremarkable, including his eye ground exam. He has normal renal function, a potassium of 4.2, and his EKG reveals a normal sinus rhythm and voltage suggestive of LVH. So, Sam, this is the last consensus document that we've had on resistant hypertension, 2008, the American Heart Association scientific statement. Dave Calhoun was the initial author. There is an updated statement that's coming out either the end of this year or more likely early 2016. So we really look forward to that. So the big questions I want to address is, 1, does Sam have resistant hypertension? 2, how important is pseudo-resistant, or what looks and feels like resistant or apparent resistant hypertension, from true resistant hypertension? And do we believe there's a benefit to controlling resistant hypertension? So 1, does Sam have resistant hypertension? Well, when we look at hypertension by age and gender, I just want you to see, since this is on the female patient, that men are more likely to have hypertension at a younger age on the far left, but as we get older, women are more likely to have hypertension as we get older. And you can see that many of us will have hypertension before we die. The definition of resistant hypertension, last really given in the 7th Joint National Committee report, the 8th, or what we refer to as the 8th JNC report, didn't deal with resistant hypertension. Just talked about the first drug, where you start therapy, and what the goal should be. 3 seminal questions. But JNC 7 in 2003 defined resistant hypertension as a blood pressure that remains above 140/90 in patients adhering to an adequate and appropriate triple drug regimen, including a diuretic, with all drugs prescribed at near maximum or maximum recommended doses. The AHA scientific statement definition agreed with that. It's uncontrolled blood pressure despite the use of 3 medications. But they had a new definition, and that was what's called controlled resistant hypertension, where your patient's on 4 or more medications, but is that the goal you've determined to be best in keeping with the guidelines for the patient. And I have a little problem with this definition because control is control, and patients should do well at being controlled, although all patients with hypertension are always at a greater risk when controlled than people that have the same blood pressure and no history of hypertension. But what I think they're trying to tell us when they're controlled on 4 or more drugs is that we should go through a mental exercise with our patients to determine if they're not doing something that's competing or interfering with their blood pressure, if they're not on the best regimen, could they have a secondary cause that might allow you, for instance, obstructive sleep apnea, to reduce a half or a full medication, even though they still may need 3 medications to further improve or control their blood pressure? And as you'll learn, there are many things associated with obstructive sleep apnea that are much more important than the return you get from CPAP on reducing blood pressure in resistant hypertension. So this is really what I think controlled resistant hypertension is all about, but it is a new part of the definition. So Sam, he's 58, he's on 3 meds, 100 losartan, 25 hydrochlorothiazide in 1 pill, and amlodipine, 10. 3 medicines that make a lot of sense, one of which is a diuretic, and I think that definition should actually be thiazide diuretic, unless they have chronic kidney disease and you need to use a loop. And he's uncontrolled in the office. So yes, Sam has resistant hypertension. Now, how important is pseudo-resistant or apparent resistant hypertension from true resistant hypertension? Well, the prevalence of resistant hypertension is not known. Depending on where you practice, the prevalence differs. In our practices, it's about 10 to 30%. Most of us, it's somewhere in the early double digits, 13, 15%. So if you have an EMR and you go in and look at all the patients above 140 over 90, you can, and on 3 meds, which you can put into an EMR, or more meds, you can see how many ICD-9 codes of hypertension are resistant in your practice. If you're a referral clinic, it can be much higher. So nephrologists may see 50% or more that are resistant. They're not often seeing the early hypertensives, so it's much more common. But if you look at the National Health Nutrition Examination Survey, of those that are being treated by us on drugs, it's about 1 in 8 or 13%. So about 13% of patients in our practices that we're treating with drugs for hypertension are resistant, and the prevalence now is increasing. We're seeing more resistant hypertension. So how important is pseudo-resistant or apparent resistant from true, and what do we mean by this? Well, on the right side of the slide is what we call pseudo-resistant. They look, they feel, they smell resistant, but they're not. They're apparent resistant. And that's because we may have an improper blood pressure measurement. After all, it's all about the blood pressure measurement. They may have a white coat effect where we think they're hypertensive, but they're only hypertensive in the office. And they may not be taking their medications, although they tell us they are. Yes, really, Dr. Piziak. These are apparently resistant, but they're not truly resistant. As opposed to true resistant hypertension, which we'll spend most of the talk on. So let me first talk about blood pressure measurement. And these are my own feelings on it, how I've set up my clinic at the medical school. I preferably like the blood pressures taken before I ever see the patient. So I'm in an area of the clinic where I will not greet or meet or see the patient until the patient comes in, signs in, and is seen by my nurse, who has a protocol she uses with an oscillometric device that allows the patient to sit in a chair, push a button, and it's 5 minutes until the first blood pressure is taken. Back supported, feet on the ground, no talking, rested, comfortable, just with the nurse. The nurse can actually leave the room. There's no conversation, arm at heart level, no tobacco or caffeine for 30 minutes. We take 3 seated readings. Some people throw out the first reading because you'll find the first reading is often much higher than the other 2. Others average the 3 readings. And then I always take an upright measurement, and that's 1 to 3 minutes after the last seated measurement. And once they're in therapy or on treatment, I often get a supine sitting and standing just for orthostatic changes. An orthostatic hypotension is the reduction in blood pressure, 20 millimeter systolic drop, with or without a 10 millimeter pulse increase. So blood pressure measurement is so important, and I don't have a problem with you using an auscultatory device, stethoscope, and deflating pressure, looking at the sphygmomanometer. But I will tell you that in clinical trials, we're using oscillometric devices because our hearing's different, our deflation times are different, and the Korotkov sounds are not always easy for us to hear as we get older. And the oscillometric devices are reliable, they're standardized, and we use them in clinical trials, and we also use them in practice. So that's up to you. I do like to get an exit blood pressure if it was high on the oscillometric device before they leave, because the government believes the last pressure is your best pressure. And it's an interesting phenomenon. So if you can show that the last pressure is lower than the initial pressures, you can use that pressure as the blood pressure of chart documentation. Let me talk about the white coat effect. This is very important in resistant hypertension. This is from a large Spanish registry where almost 8,300 individuals got 24-hour ABPM. And in this large registry, when they went back and looked at the patients, they found that about 12.2% were on 3 or more medications, and they had high pressures in the office. So they were considered offer-resistant hypertension. And when they looked at their 24-hour ABPM, they found that about 1/3, or 4.6% of the total treated population, actually had white coat resistant, that is, their 24-hour ABPM were not impressive, whereas their clinic pressure was elevated, and 2/3 had true resistant hypertension. They not only were high in the clinic, but they were high outside the clinic by the burden of blood pressures above the standard that we use on ABPM. The point here is that don't be surprised by the number of people that actually have white coat hypertension, even when they're on 3 meds. How does this happen? Dr. Pisiak saw the patient first. The patient then comes into my practice. Now, I know Dr. Pisiak's a very good clinician, so I never questioned the fact that she put the patient on lisinopril HCT or losartan HCT, and the patient was elevated. Well, the patient moved from Temple, Texas, and now is in Charleston, South Carolina. So I saw the patient, and I added a 3rd drug. And now the patient's still not controlled on the 2nd visit, because I never thought of getting an ABPM to make sure the patient truly has resistant hypertension or hypertension and not white coat. So I'm going to throw that out, and at the end I'm going to redefine resistant hypertension to tell you how important the 24-hour ABPM may be in this diagnosis. And then finally, let me talk about medication adherence. Because patients often do not take their medicines, they often do not fill their medicines, and unfortunately, the pharmacist will often take the medicine off the shelf, and because they're not always paid or not paid to call the clinic or get in touch with the clinician, we never know until 3 months or 6 months later, unless we have the patient bring us their last bottle of medication that was filled, or unless we're in direct communication with the pharmacy through e-scripts, and until the government pays us for working together, for all the effort and energy that it takes, we may not know that the patient never filled the medication. Because we have an understanding, we write the prescription, a lot of us through e-scripts, we assume they'll go to the pharmacy, they'll fill the medicine, and they'll take it. And I think we need to have a strong communication with patients, that we have an understanding that you will help me help you to control your blood pressure, control your diabetes. I'm writing this medicine. I'm going to assume you'll fill it, take it, unless I hear from you. And if I hear from you, I will get back with you. Someone in my office or myself will call you. We will discuss it. But unless I hear from you, I assume you take the medicine as I write it, because it's what I feel is best to control your blood pressure. Now, in Germany, they did a very interesting study that I highlight here of 375 patients referred for uncontrolled hypertension, resistant hypertension on 3 drugs. But interestingly, in this particular study, they were able to do what I hope in the future we will be able to do, and that's fluorometric evaluation of antihypertensive drugs by urine screening. Well, when they looked at the protocol the patient was being treated with, they found that just by maximizing the doses of the agents and by excluding white coat by 24-hour ABPM, that is excluding apparent resistant or pseudo-resistant, they ended up with less than 1/3 of all the patients. And then, as I'll show you, they went through the secondary causes of hypertension, and they added one more drug. They then got rid of almost 3/4 of the patients, down to about 1/4 of all patients. But then when they looked at those patients that were uncontrolled, they found that more than half were non-adherent. 30% were just flat out not taking any of the meds by fluorometric analysis in the urine when they did urine screens on all these patients as protocol. But 85% were taking some of the medicine, but less than half, which is baffling, isn't it? So patients are good people. They come into the clinic like I used to come into my piano lesson, And when my piano teacher knew I hadn't practiced all week and that I was practicing, she would say, "Did you practice your lesson that I told you should have mastered and shown me you mastered today before we get into what's new and I'm trying to teach you?" And I would look and say, "Oh, I practiced." I didn't practice. I was doing all the sports. And, so like Dr. Piziak, my piano teacher told me, "You ever come here again and show me that you haven't practiced, I'm not going to continue to teach you because I have too many people on a waiting list." And that got me, And the same thing with people not taking their medications. So in essence, there are a lot of reasons that we think they're resistant, including they're not adherent to their medicines, where we need to be more vigilant and work with our patients to make sure they're adherent on the medications, because these medications work. They lower blood pressure, and I'll show you how possibly we can get around this in the future. So how important is apparent or pseudo-resistant? Very important, and it accounts for about 50% of the people we think are resistant. Poor measurement, white coat, not taking the meds. So let's talk about true resistant hypertension. We've ruled those things out. Do we believe there's a benefit to controlling resistant hypertension? The answer is yes, but the degree to which cardiovascular risk is reduced with treatment is unknown. However, the benefits of successful treatment are likely to be beneficial, substantial, and that's from the Calhoun paper. But two recent studies that you're probably familiar with have found that resistant hypertension is associated with a twofold increased risk of cardiovascular morbidity and a 50% higher risk for cardiovascular events. And I'm going to share the TNT, Treat to New Target lipid study, and the recent All-Hat post-hoc study, which found significant increases in coronary heart disease, stroke, death, and heart failure in the third of the patients who were resistant. So this is the TNT study, and this is published in the American Journal of Medicine. And what they say is in patients with coronary artery disease, apparent treatment-resistant hypertension, they're on 3 or more meds uncontrolled in the clinic, is associated with a marked increase in the risk of cardiovascular morbidity and mortality, including an increase in all-cause death. All these patients had hypertension and coronary disease. They were put on either atorvastatin 10 or placebo. But notice, in those that are resistant, either on 3 or more meds and greater than or equal to 140, or on 4 meds and even controlled, look to the far right, that the risk is increased in this pedogram or forest plot for all of these vascular events in those that were resistant within the TNT study. And in the All-Hat study, remember that 2/3 were controlled. 67% were controlled by the end of the trial, but 1/3 were not controlled to less than 140/90 or less than 130/80 if they were diabetics, a goal that we no longer recommend in hypertension. Only 2 goals are recommended, less than 150/less than 90 and less than 140/less than 90. However, in All-Hat, mean follow-up 5 years, of those that weren't controlled within All-Hat, and we look at their outcomes, 44% increase uncontrolled CHD, 57% stroke, 88% heart failure, 30% death increase, 95% end-stage renal disease. And this slide also tells us the following, that the target organs most responsive to blood pressure control are the brain and the heart. We have the greatest return on our efforts with stroke reduction and heart failure reduction if we control blood pressure, and that's nicely shown here, although all of these cardiovascular events and renal events are related to control of blood pressure. So we do believe there's a benefit to controlling resistant hypertension. So what's the checklist that we go through? Well, we want to identify reversible causes of hypertension if they're resistant. We want to look for drug-induced or other causes, so-called substances that are competing with what we're trying to do, or interfering substances. We want to recognize volume overload, which often occurs when there's no edema. There's too much volume in their vasculature, which raises their blood pressure. Could they have hyperaldosteronism? Not often from a tumor, but from reactive hyperaldosteronism. Are they obese? Are they taking in too much alcohol? Do they have sleep apnea? And do we suffer from clinical inertia? And I'll talk to you about that in a minute. So The workup for hypertension is very simple. What do we recommend for all hypertensives? A CBC, a UA, a basic metabolic profile with a sodium, potassium, and creatinine, an EKG. We don't recommend a chest x-ray, and we don't recommend other sophisticated tests. But when they're resistant, we want to rule out hyper and hypothyroidism. We'd like to rule out a pheochromocytoma, but clinically many of these things are suggested. We want to be aware of the presence of reactive hyperaldosteronism or tumor-associated Conn syndrome, where there's an adrenal aldosteronoma. And the hallmarks of that are normal potassium or low normal potassium or reduced potassium. But even if potassium's normal, the sodium may be normal when the sodium's 140 and the K is 3.5, or when the aldo-renin ratio is elevated. But the aldo has to be more than 12 to 15 nanograms per cc by itself. And these tests are done just seated. So because the renin may be very suppressed from your ACE or whatever you're using, a lot of times the aldo-renin ratio is very high. If the renin's 0.2 and the aldo is 7, the ratio is 35, but the aldo's only 7. So the aldo itself has to be elevated, okay? Please remember that, okay. Cushing's clinical, hyperpara, chloride phosphorus ratio, hypercalcemia on the basic metabolic or the advanced metabolic panel. Renal artery stenosis is very, very controversial, and depending on where you practice locally, you can either get a duplex ultrasound or magnetic resonance angiograms. The MRA is more expensive. It has more radiation, of course. But there's a recent study called the CORAL study, which showed that medical therapy was as good as intervention. So right now there's sort of a moratorium on what best to do for renal vascular hypertension that occurs from renal artery stenosis. No question, fibromuscular dysplasia does very well with angioplasty. This is the young hypertensive, often new onset, but very high pressures, or previously controlled and now all of a sudden out of control. And in those patients, I'd really look for fibromuscular dysplasia, white or black. It's common and something that should be looked for. On the other hand, atherosclerotic renal vascular hypertension, as I said, is a controversial area. And then finally, sleep apnea. We'll talk about that. Hypersomnolence, daytime sleepiness. Spouse tells you they snore, never feel rested, that kind of suggestion. Not necessarily on the obesity of the patient, but probably more on the neck width, circumference, and just a high suspicion for the possibility of this. These are the interfering substances. Let me just say a word about NSAIDs. In general, NSAIDs raise systolic pressure 5 millimeters in all of us, chronically used, 12 to 14 millimeters in hypertensives. If you don't have to be on an NSAID, don't be on an NSAID. I like Trilosate, choline magnesium trisalicylate. It's generic, it's inexpensive, doesn't raise blood pressure. All these other things are associated with elevation in blood pressure. They interfere with what we're trying to do, including over-the-counter meds. So I have patients bring all their meds, those that specialists write, those that I write, anything they buy over-the-counter, non-judgmental, just bring them all in a bag, and I've always been looking at those on a particular area of the desk where I sit with the patient. Volume overload, yes? Yes, choline magnesium trisalicylate, or it's known as Trilosate. Interestingly, a recent study compared to placebo showed that it lowered A1C. It's a very interesting medication, but it's a non-acetylated salicylate. Non-acetylated salicylate, BID 750 or 1,500 milligrams. No, it's prescription, but not expensive. What about volume overload? There are many patients with too much volume in their vasculature, but they have no edema. And the other thing is the sodium in their diet. So these are very important properties and appropriate diuretic use. So let's make some points on this. This is a very important, classic, but small study of 12 patients, all serving as their own control, on an average of 3.4 blood pressure medicines and referred to the University of Alabama for resistant hypertension. Their in-office blood pressure, bottom left, was 146/84, and they were, on average, 3 to 6 grams of sodium in their diet. They then were double-blindly randomized to either a low or high salt diet. The low salt diet was almost an unpalatable 50 millimoles of sodium a day, or 1.15 grams of sodium. And the other half were on a 5.75 gram sodium diet. 1 week on the diet. For 2 weeks, they were washed out of the diet, and then they were crossed over, serving as their own controls. A number of studies were done. When you look at the blood pressure reduction going from the 250 millimole to the 50 millimole salt reduction, you can see a 20 millimeter reduction in systolic pressure in these folks. Salt excess is a culprit in resistant hypertension. And I think that if we can get a handle on this, clearly using a dietitian, using a spot urine sodium, however you want to do it, even on a diuretic, it'll give you a handle on how much salt people are taking in their diet. Processed foods, salt shaker, a good dietary history, using a dietitian. I hope in the future that the payers will allow us to treat these disease states and not have to pay for an extra visit or an extra encounter with people like dietitians, who I think in a proper medical home should be part of the diagnosis of hypertension. But you can see what high salt to low salt diet can achieve. Let me say a word about the first 3 drugs in hypertension. This is what we published in JNC 8. It's in no particular order: a thiazide, thiazide-like diuretic, a RAS blocker, and a CCB. And I know that if any of you had hypertension, some of you might believe that the first drug you'd reach for would be a RAS blocker. Because how could a RAS blocker not be the better drug compared to a CCB or a diuretic? And the reality is it's all about blood pressure reduction. We've never had a clinical trial that has shown one drug to outperform another for outcomes unless it at least lowered blood pressure as much. And in blacks, diuretics and CCBs lower blood pressure on average much more than RAS blockers. In whites, RAS blockers. In the elderly, diuretics and CCBs. In the younger patient, a RAS blocker. But when you use these 3 drugs as your first 3 drugs, you're going to control the vast majority of patients with hypertension. Beta blockers can be used, certainly post-MI, for the first 2 to 3 years, and if they have heart failure with reduced EF, which we'll talk about after the break. But I have patients referred to me on a beta blocker, clonidine, and lisinopril. Now think about it. Does that make sense? Do those drugs interact well? Do they take care of the volume component of hypertension? So I'm not sure why someone would do that, but they do that. These 3 drugs work very well together. They may raise renin, but the other drugs might lower it. They may cause salt retention, but other drugs reduce salt retention and volume. So these 3 classes of drugs are just great together. And our patient was on losartan, HCT, and amlodipine. 3 good drugs as the first 3 drugs. Now, when you look about gender, and we are talking about the female patient, separate patient-level meta-analyses were performed years ago in 7 clinical trials involving 20,000 women and 19,000 men, and the summary odd ratios, confidence intervals, and p-values for interaction were: there really is no difference, men versus women, in the drugs we use for hypertension. To summarize it, we say the following. For bone mineral density, we like women to be on a thiazide-like diuretic. For pregnancy, we like women not to be on an ACE, an ARB, or a direct renin inhibitor. But other than that, we really can't say that outcomes are different based on a particular class of drug in men versus women, and you can see the P interaction is not significant, and the outcomes are very successful. So independent of gender, all patients do well with blood pressure control. However, you might get an off-target effect from the calcium reabsorption of a thiazide diuretic, not that we can prove it for fractures, but for bone mineral density. So a thiazide makes sense in a woman, and pregnancy might have some other factors. Other than that, not much interaction by gender. Treatment benefit did not differ by gender. That still stands today. When you look at the gender differences in the drugs, and I just put this in as just a little addition to stay on the topic of our female patient, Diuretics are associated in your minds with more erectile dysfunction than non-diuretic therapy, but in double-blind randomized trials where I don't know what they're on and you don't know, and the patient doesn't know what they're on, it's very hard to show that. So we bring a little bit to the table, and here's what I think. I think when you first start lowering blood pressure in people that have had hypertension and uncontrolled blood pressure, the blood pressure reduction you transiently and initially get before you're at goal causes a reduction in pressure in the penile pressure, and this causes just a loss of fullness of erection. And what I tell my patients is stay with me on this. When I get you to goal, if you still have erectile dysfunction, I will change the medicine. But let me first get you to goal and see what happens. Now, of course, if they become flaccid, I have to look for something else. Beta blockers can do the same thing. So there is one study in the hypertension literature that suggests exactly what I'm telling you. So perhaps we shouldn't be so quick to pull the trigger and get rid of the thiazide diuretic or the beta blocker as we initially lower blood pressure. This is more common in stage 2 high pressures than stage 1 as we lower the pressure. And of course, CCBs with pedal edema, verapamil can cause constipation, and the ACEs and the ARBs can cause cough and be associated. The ACEs with angioedema. The ARBs not so much, although sometimes you get sporadic angioedema on an ARB, and you call it ARB-associated angioedema or ARB-caused angioedema when it may just be someone on an ARB who actually just gets sporadic angioedema. So that's a complicated issue. Which thiazide? I don't have any dog in this fight. If your patient's controlled on what you're using, I can't argue. But if they're not controlled or resistant on hydrochlorothiazide, I'd like to make a strong effort for chlorthalidone. Why chlorthalidone? Because chlorthalidone has a very long duration of action, as opposed to HCTZ, which truly should be a BID drug, although we only give it once a day. Hydrochlorothiazide has a half-life of about 11 to 16 hours. Chlorthalidone, 1 to 3 days. Chlorthalidone is a much more evidence-based thiazide diuretic at the doses we use, because we don't go above 25 in almost all of our patients with hypertension. And although on this slide the evidence suggests that at 50 to 100 milligrams of hydrochlorothiazide, we have good evidence for outcome improvement. When we reduce the dose of the thiazide in the 80s and early 90s to 12.5 to 25, we still control blood pressure, but we don't have evidence that the outcomes are improved. This is a controversial area, and I say if you're controlled on 12.5 to 25 because you like lisinopril HCT as a $4 drug, I can't argue with it because they're controlled. But in resistant, if they're not controlled, there is some evidence that chlorthalidone is longer in duration. It's about twice as potent. This is 25 of chlorthalidone compared to 50 of HCTZ. Small study, double-blind, randomized. They don't know what they're on, I don't know what they're on. And we do ABPMs. And although there's always a tendency from left to right for systolic blood pressure to be better reduced on chlorthalidone 25 than HCTZ 50, on the far right, the dipping is much better. The nocturnal blood pressure is significantly better. Chlorthalidone to me is a Cadillac of diuretics, thiazide-like diuretic, that you all don't often use. But specifically in resistant hypertension, as this classic study shows, when they're not controlled on the far left on HCTZ at a mean blood pressure of 152, and you just switch them over to the same dose of chlorthalidone, you have a much better chance of controlling their blood pressure. Furthermore, in this industry-sponsored study that looked at an ARB with hydrochlorothiazide versus an ARB with chlorthalidone, the same ARB, you can see at the end of 6 and now 10 weeks what is the difference by either clinic or ABPM blood pressure. And when you compare azelsartan chlorthalidone 40-25 to azelsartan hydrochlorothiazide 40-25 in non-resistant patients, look at the difference in systolic pressures. Double-blind randomized trial. So this just shows you the power for blood pressure reduction of chlorthalidone compared to hydrochlorothiazide. Will you use it in everyone? Perhaps not. Will you use it in yourself? Perhaps so. Will you use it in resistant hypertensives? I hope so. So I like chlorthalidone in resistant hypertension at 12.5 to 25. Yes, the metabolic complications are slightly worse. It's more potent. It causes more hypokalemia, but we don't see it now that we're using ACEs and ARBs with the chlorthalidone. And it may be given with spironolactone. But remember, these drugs, when they're given together, Spiro and chlorthalidone, can cause hyponatremia. Okay, hyponatremia. Okay, now let's look at spironolactone, because this is a great fourth drug in patients with resistant hypertension. 12.5 to 25, like chlorthalidone, you may go higher. Hyperkalemia is uncommon if they have good renal function, but let me tell you about the 45, 4.5 rule. If your GFR is less than 45 in Mr. Jones, and your baseline K is 4.5 or greater, and you add spironolactone to an ACE or an ARB, you've got to be more vigilant about looking at the potassium in these patients. But if the K is less than 4.5, or the renal function is good and they're not on an NSAID, you will not get into trouble adding spironolactone to an ACE or an ARB. So this is a good rule to remember. And in general, Spiro only has to be used for reactive or non-tumor associated hyperaldo at 25 milligrams ceiling dose. So like chlorthalidone, you can start at 12.5 and go up to 25. I don't see much gynecomastia in these days because we're not using it with DIG. Back in the day when we had no ACEs and ARBs and we used heart failure, a lot of DIG and Spiro 3 times a day, we did see gynecomastia, breast tenderness. Today we use Spiro once a day because we know it's a long-acting drug. Even the gastroenterologists are using it once a day. And we're not seeing the gynecomastia. Let me talk a little bit about loop diuretics. Loop diuretics are venodilators. They are not antihypertensive, but they are blood pressure lowering. So if you're forced to use a loop diuretic, you will have additional blood pressure reduction. But it's not a true antihypertensive. It doesn't work on the arteriolar side. It works on the venous side. So it gets rid of salt and water, and it does lower blood pressure. But unless the GFR is less than 30 to 35, where chlorthalidone will work, HCTZ stops working at about 35 to 40. So you could switch to chlorthalidone if the renal function is a little more compromised. But if you have to go to a loop diuretic and you use Lasix, please use it 2 times at least a day because it lasts 6 hours and you need more sodium blockade for the other 18 hours where there's paradoxical sodium reclamation in the collecting duct, and that sodium that was initially blocked in the proximal tubule is now reabsorbed avidly. So you're going to get more sodium reabsorption than you wanted if you use Lasix once a day. Spironolactone, there's a lot of idiopathic hyperaldosteronism. It's unrecognized, but it's present. And when we've looked at our clinical trials and just observed what happens to blood pressure when we add spironolactone as a 4th drug, we see tremendous reductions in blood pressure. 22 millimeters of systolic reduction, almost 10 of diastolic, just by adding spironolactone 25 to 50 as a 4th drug with very few adverse events. Okay, so a couple of tools we've talked about, a couple of tricks. Now let's talk about associated conditions. Alcohol intake causes sympathetic nervous system overreactivity. Obesity is associated with volume excess and sympathetic nervous system overactivity. So the obese patient does well on a sympathetic nervous system blocker like a RAS or a beta blocker and a volume reducing agent like a diuretic. Sleep apnea is associated with both mineralocorticoid activity excess, so Spiro or eplerenone can be used, and sympathetic nervous system activity excess. CPAP reduces blood pressure but does not cure hypertension. So let's talk about sleep apnea. This patient's waiting in your office. You know what he's got. He's uncontrolled. When you look at the effect of CPAP on resistant hypertension, the effect is modest at best. And devices have less effect on blood pressure than CPAP. So in this classic study, published in 2013, In 194 patients with resistant hypertension and an apneic-hypopneic index of greater than 15, with the primary endpoint being the change in 24-hour mean blood pressure by ABPM, looking at CPAP versus no CPAP. The changes with CPAP, double-blind randomized trial, in which there was a sham CPAP used versus active dial-up CPAP, the blood pressure reductions were minimal. They were positive, they were significant, but they really weren't all that impressive. We say about a half of a medication. But because obstructive sleep apnea is so linked with stroke and MI and heart failure and atrial fibrillation and chronic kidney disease, we need to be committed, even if it doesn't give us that much return in resistant hypertension, to identifying these folks for all the other comorbidities sleep apnea is directly linked with. So it's an evolving science. Stay tuned. We need better tools to allow patients to diagnose this at home. And this is coming because it's expensive and we don't have that many sleep experts or pulmonologists to do the number of tests that are required. Then finally, let me talk about clinical inertia. Now, this is where the failure of us as healthcare providers initiate or intensify therapy when indicated. This is when we play Monty Hall with our patients. Dr. Basil, I'll do anything, but not more medicine or another medication. And I look at them and I say, haven't you been doing everything? You're still uncontrolled. Your ABPM shows me you have severe hypertension. I need to do a better job. Why are we arguing over the fact that you need another medication to better control your blood pressure? But when we look at uncontrolled hypertension in the National Health Nutrition Examination Survey, 52% were untreated, 14% had apparent resistant hypertension because we hadn't done an ABPM and we're worried about the measurement artifact and adherence. But 34% were on 2 or fewer medications and still uncontrolled. Why didn't the clinician up-titrate more medication? Why did they remain on 2 or fewer medications when they were uncontrolled but being treated in 1/3? And in our own data set from the Hypertension Initiative of South Carolina, Georgia, and North Carolina that Brent Egan led, and I was part of, when we looked at those patients that were uncontrolled and looked at the providers' EMRs, if you didn't suffer from therapeutic inertia in red, you were more likely 77.6% of your patients to be controlled than if you suffered from therapeutic inertia. So we cannot suffer from this. We need to be effective clinicians, use more medication when indicated, and get our patients to trust us and take the medications as indicated. So there's your checklist. I just want to say a word about devices. They're not ready for prime time. They're not FDA approved. We'll see what happens in the future. But we have 2 devices, one of which is tunneled unilaterally through the carotid sinus that fakes out the carotid sinus to cause increased parasympathetic discharge, to cause less sympathetic discharge, and cause less vasoconstriction, sodium and water retention. And the other is renal denervation, which still is being reevaluated, different patient populations to look at, not just resistant hypertensives. Recently, the Simplicity Hypertension 3 trial had a major setback. This was a double-blind sham operator procedure where the patients who didn't get the procedure actually thought they may have gotten the procedure. The same script was read to them. There could be no difference detected in who was ablated versus who wasn't, and the results were not positive. There was no difference. So in this editorial in the New England Journal article, they write, the time has come to turn the page on renal denervation for hypertension, but by all means, let's not close the book. So stay tuned, more to come, but at this time, we have no devices that we can approve for resistant hypertension. And then finally, the last thing I want to end with is this slide. This is from a Spanish registry that is done by a fellow by the name of Hermida, and we haven't been able to reproduce Hermida's results, but what he's done is to take the 3 medicines patients are on or more for resistant hypertension and just give one of them at bedtime. And when he gives one of those patients at bedtime, he now has a significant better ability to control blood pressure than when all of them are given in the morning. And what we say is if you're on the CCB or RAS blocker, give them at bedtime. When they get into bed with a little water, take the thiazide in the morning, but you don't have to take all 3 in the morning. And that little trick in his registry of Spanish patients, some of whom had diabetes, some of whom had CKD, and most of whom had just resistant hypertension, the other 2 comorbidities with resistant hypertension, he now was better able to control them. So in the future, we may define resistant hypertension as an elevated blood pressure in patients fully adherent to maximally tolerated doses of multiple drug regimens, including a long-acting thiazide diuretic, chlorthalidone preferred, and a mineralocorticoid receptor antagonist like spironolactone, while on a low-salt diet. In addition, as part of their workup, patients should have a 24-hour ABPM placed on the morning after you personally administer their medications or your nurse to confirm true resistance. You want to know what the ABPM is when you give them their medications. And rule out white coat resistant hypertension, emphasizing once-a-day medications when possible should improve adherence even if one or more of the antihypertensive medications is taken at bedtime. So, Sam is a 58-year-old fella, a real patient, resistant, has the 24-hour ABPM, he's resistant, he's taking his medications, plan. Over time, we changed losartan HCTZ to azlosartan chlorthalidone. Then 6 weeks later, we added Spiro, and by 3 months, his blood pressure was 128/82. No change in renal function. K didn't change much. He thinks that I'm a hero because no one else could control his blood pressure. Just made some small changes. Summary, resistant hypertension is a medical problem that is increasing in prevalence and of clinical concern. Mechanisms are multiple, but aldosterone excess and high dietary salt ingestion contributing to persistent intravascular fluid retention without clinical edema appears to be an important contributing factor. Treatment is predicated upon lifestyle changes, combining agents from different classes at effective doses with effective use of diuretics, including mineralocorticoid receptor antagonists such as spironolactone. Future approval of device therapy in the U.S. to treat resistant hypertension remains uncertain, but is being studied further. So let's go back to our questions. According to the NHANES data set, the estimated prevalence of resistant hypertension in the United States is A, B, C, D, or E. Please answer now. So I'd like you all to do that. Those of you who did it earlier, would you please do this? So will this?
That's not the text. No, that's not.
Oh, this won't?
That's not got the full everywhere stuff in it.
Oh,
So,
she didn't do that to see how much they learned.
They learned a lot.
They learned a lot. Thank you, Ronnie. So raise your hand. How many think it's A? Quickly. Don't look at your neighbor. B? C? Very good. About 13%. Approximately what proportion of patients with resistant hypertension by clinic measurement are shown to actually have white coat hypertension when using 24-hour ABPM? Quickly. A? B? C? D? Good. Nice. On a scale of 1 to 5, please rate how confident you are in treating a patient with resistant hypertension. Raise your hand. 1, 2, 3, 4, 5. Okay. Well, that I don't have an answer for. Okay. So, questions? We have 5 minutes. Dr. Pisiak has a question, and then I'll take yours.
Yeah. How do you get the insurance company to pay for ambulatory blood pressure monitoring? I mean, that is so important, and it's really hard to get people to pay up.
Okay, so the insurance companies will always pay for white coat hypertension, and that's an ICD-9 code. And how do you diagnose that? 3 separated blood pressures in the clinic by a week apart, at least, always high, in a patient with hypertension with no target organ disease. So they don't have creatinine elevation, They don't have a history of vascular disease. You look in their eye grounds and you can't really account for much bad stuff going on. And that's white coat hypertension. So they'll pay for that. And here's what they'll pay. They'll pay about $62. Yeah, that's what they'll pay. And so it's a little bit of a problem. Now, they'll also pay if they're resistant and you think it's white coat resistant, but you've got to work with them on this. So that can be a problem, Ronnie, and you are head-on correct. It's an excellent question. We have a problem in hypertension because the United States Public Service Task Force late last year issued a statement that they put out to the community, our communities of practice, stating that in their opinion, all newly diagnosed hypertensives, like the British said in 2011, should have an ABPM. All newly diagnosed hypertensives. Why? Because there are patients that we, in clinic, diagnose with hypertension, and they actually are not hypertensive. They're reactors or alerters. And I think out-of-office blood pressure measurement is very important. And when they tell you, doctor, it's always fine out of the office, but only high in the office, an ABPM will be helpful. When they tell you it was always normal out of the office, and you started treating me, and now I'm feeling weak, lethargic, and dizzy, and I'm taking your medicine, and now my pressure's a little better, but I don't think I was ever hypertensive to begin. You know, that's the kind of patient that we're talking about, who has the alert or white coat response. So it's an issue. I think the two greatest areas where we need ABPM is white coat hypertension and an all resistance. Let's see what the 2016 guideline says about the role of ABPM to confirm true clinic resistant hypertension. Yes?
Are there any studies being done on using medicines for hypertension and heart disease? I had a cardiologist recommend maybe using guanfacine for those patients.
Okay. Very interesting. Where do you practice? Very nice. So let me tell you a couple of things. First of all, there is a true syndrome in hypertension that you can Google and should read about called pseudopheochromocytoma. I've been referred several of these folks. They are very anxious alerters in their environment. They have hypotensive symptoms on multiple medications. They have no target organ disease. They have palpitations. They sweat. And they can get ill-defined headaches. Their metanephrines and norepinephrines or 24-hour workup is normal. Everything you do is normal, and they have a pseudopheochromocytoma. They look and feel and smell like they have the palpitations, headache, pallor, perspiration, etc. of a pheo, but they don't. And it's well described in the literature. And in those patients, and in my patients that I saw, Ativan 0.5 TID is a great drug. Calms them, lowers their pressure, and the other thing is it's so reassuring to them to know they're not crazy. They have an illness, and it's pseudopheochromocytoma. And they're not going to die from their blood pressure, at least we don't believe so, because their blood pressure elevation is sporadic. Okay? And you can do a 24-hour ABPM, which I was able to do, to prove this to the patient. So I'm not against anxiolytics in some people who have an alert reaction or are anxious, and that raises their blood pressure. I think my blood pressure is a little higher when I speak, maybe Dr. Pisiak's. I think all of our pressures are higher if we have intimate contact with another individual, but we don't take antihypertensives or anything there because it's transient. Guanfacine is a good drug. I don't like it as an initial 3, but it can be used in the specialized patient, so I have no problem. I like guanfacine, long-acting. It's a reserpine-like drug. I like it. So yes, I think anxiolytics can be helpful here. Yes?
When you look at the 3-drug regimen you talked about,
Yes.
at what level do you use about 50% of your second medicine as the dose, and then you add your third, or how do you do your math?
Okay. So I didn't have time to go through this, but the evidence is very strong. And Dr. Pisiak actually hinted at this in one of our comments on the hypertensive case. You will always get so much more blood pressure reduction by adding a drug of another class than by doubling the dose or maximizing the first drug. So I am much more in favor of lisinopril 20, adding lisinopril HCTZ, if you haven't started the two together from the get-go, than up bumping to the 40 of lisinopril. However, afterwards, I may go up to the 40 of lisinopril. The problem is you can't get lisinopril 40 12.5. Okay, so that's a problem with the way it's formulated. But we say in hypertension, you will always get 4-fold greater blood pressure reduction by adding a drug of another class that interacts favorably, metabolically, with the first drug than doubling the first drug. And that's been well looked at by a fellow by the name of Malcolm Law, well published in Hypertension. So I love the second drug before doubling the first. Now, you may backfill later. Let's say they have diabetic nephropathy. So they're on losartan, HCT, but now they're controlled, but they're only on 50 of losartan, and they have that nephropathy. You may go up to the 100 because of the proteinuria, but you may not. And I feel the ceiling doses of drugs are, for instance, lisinopril 40, amlodipine 10, hydrochlorothiazide 25, although I really believe it's 50 to 100, clothalidone 25. And you can just throw out drugs, and I would tell you, the ceiling dose. It's in the JNC7 report in one of the tables. But I like 2 drugs before just one. Don?
When you look at all these studies about the effects of lowering blood pressure, a good study drops the systolic or diastolic by 10 millimeters of mercury. These real small drops in blood pressure with what we observe as great clinical benefits have always bothered me a great deal. Do you think maybe what we're seeing is the effect of the drugs in other aspects that makes the difference? We learned this in statins. It wasn't the cholesterol that was the major issue. It was the anti-inflammatory component to the statins, stabilizing plaque. I've always wondered in these studies where you see dramatic results from small incremental
Yeah.
blood pressure, whether we're looking at something that are not working. If the question is, if anybody looked at the actual mechanisms of why these outcomes are so much better other than blood pressure reduction.
Well, in hypertension, we believe that small changes in blood pressure in high-risk patients translate into large benefits in outcome. If you look at the clinical trials we've done, most of the patients have had stage 2 hypertension, 160 or greater. We don't have many studies with patients entering at 140 to 149. We have more at 150 to 159, and many at 160 and above. When you get elderly people like in Shep with a mean blood pressure of 177 over 78, and you reduce their blood pressure compared to placebo, 12 over 4, down to 140, let me get it right, 142 over 68 compared to 152 over 72, stroke, heart failure, all go down. So, Don, I have to disagree with you, and let me just back up by saying, I think the major effect of statins for outcome improvement is on LDL reduction. I think there are other off-target effects that are pleiotropic and beneficial. But I really believe that the majority of anti-atherosclerotic effects are on LDL reduction. And for acute coronary syndrome, I think plaque stabilization is very important. What I don't want people to leave with, and I want you to leave with, is that understand that even in your patient that you've had small changes in blood pressure in, if they were at high risk, you have done tremendous good. If we went to Haiti and just put amlodipine in their water and were able to reduce their mean blood pressure, which currently, let's say, is at 152, and we could reduce it to 148, we would do those people tremendous good. And that's one of the new strategies that the World Health Organization and the World Hypertension League is trying to promote. And that is move the mean blood pressure of our populations down by diet, by lifestyle. That's what a major effort. So small changes in blood pressure do translate into outcome benefit, and the outcomes are better for stroke than coronary heart disease, very good for heart failure. So I'm a proponent of that. Don't minimize that. Okay. So with that, we're going to break. We'll come back after the break. We're coming back at what time? 9:45? Okay, so we only have about 8 minutes. I'm sorry I ran into your break. Thank you very much.